Hello and welcome. Today, we are going to be decoding the really complex world of spinal cord injuries. We're going to break down the critical system that clinicians use to assess and classify the damage, which helps create a much clearer picture of a patient's condition and, what their path forward might look like. So let's imagine this. A person suffers a spinal cord injury. The damage is done. But the huge question for any medical team is, what is the extent of that damage, really? Is there some kind of standard way to measure it, to talk about it, and maybe even predict what might happen next? Well, that's exactly the problem we're going to tackle today. All right, here's our roadmap. We'll kick things off with the most basic classification of these injuries. Then, we'll dive right into the details of the ACIA motor exam. That's the gold standard for assessment. After that, we'll see how this exam helps us identify two really different injury patterns, Brown-Séquard and central cord syndrome, before we put them head-to-head to see why these distinctions matter so much.
Okay, so to make sense of any spinal cord injury, everybody involved, we're talking surgeons, therapists, the whole team, they all need to be speaking the same language. And that's where classification comes in. It all starts with one really big distinction.
And that distinction is the injury complete or incomplete? A complete injury means a total loss of motor and sensory function below where the damage happened. Think of it like a clean break in the highway. Nothing's getting through. An incomplete injury, on the other hand, means some signals are still making it past the crash site. There's some function left. And this difference is absolutely critical for figuring out a diagnosis and what the future might hold. So how do we actually figure out if an injury is complete or incomplete, and to what extent? For that, clinicians all over the world turn to one universal tool, the ASIA Impairment Scale. Now, this isn't just some casual checklist. It is a super rigorous standard that's maintained by the American Spinal Injury Association and the International Spinal Cord Society. And that's a big deal, because it ensures that an assessment in one country means the exact same thing in another, which is just vital for both treatment and for research. A really core concept in this exam is the myotome. Here's a way to think about it. Specific nerves that leave the spinal cord at different levels are in charge of controlling specific groups of muscles. A myotome is just one of those muscle groups. So by testing the strength of these key groups, you can basically create a map of nerve function and pinpoint exactly where the spinal cord has been hurt. And how do we test that strength? With a pretty straightforward 6-point scale. It grades muscle power from 0, which means total paralysis, all the way up to 5, which is normal strength. This scale is really the heart of the motor exam. It gives us a clear, objective way to measure function. So let's break down what each of those numbers actually means. Okay, let's walk through it. A score of 0 is total paralysis, nothing's happening. A 1 means you can see or maybe feel a little muscle flicker, but the limb itself isn't moving. A 2 means the muscle can move, but only if you take gravity out of the picture, like sliding your arm across a tabletop. Now a 3 is a huge milestone. That's active movement against gravity. It's a critical turning point because it means the patient might be able to start bearing weight. A 4 means they can fight back against some resistance, and a 5 is just normal, full strength. So let's see how this works in the real world. Here, a clinician is testing the hip flexors. Those are the muscles that lift your knee, and they're controlled by the L2 spinal nerve. By pushing against the leg, they can assign a grade that tells them how healthy that specific nerve root is. They do this for key muscle groups all over the body to build that functional map we talked about. After testing all the key myotomes and sensory points, all of that data gets boiled down into a single grade from A to E. An AIS-A is a complete injury. No motor or sensory function is getting through way down low. AIS-B, C, and D describe different levels of incomplete injury, and AIS-E means everything is back to normal. This one letter gives you a really powerful summary of a very complex situation. Okay, now that we have our classification system, let's see how it helps us understand some specific real-world injury patterns. First up is a pretty rare but fascinating condition called Brown-Séquard syndrome. The story of this syndrome actually starts way back in 1849 with its namesake, Charles-Édouard Brown-Séquard. He was the first to describe these really unique symptoms after he did an experiment where he cut one side of a guinea pig's spinal cord. It's one of those classic medical stories. So what is it exactly? Well, Brown-Séquard syndrome is what happens when only one half, so just the left or the right side, of the spinal cord gets damaged. This hemisection is pretty rare, but it creates this very distinct and honestly peculiar set of symptoms because of how our nerves are all wired out. Now, here's the crucial and kind of bizarre part. The symptoms are crossed. On the same side as the injury, the patient has weakness or paralysis and loses the sense of fine touch and proprioception, which is your brain's awareness of where your body is. But on the opposite side of their body, they lose the ability to feel pain and temperature. It's wild, and it happens because the nerve pathways for these different feelings cross over at different spots in the spinal cord. So just how rare are we talking? Well, it's estimated that it only accounts for about 2 to 4% of all traumatic spinal cord injuries. The classic cause is usually some kind of penetrating trauma, like a stab wound, that physically damages only one half of the cord, but leaves the other side pretty much untouched. All right, now let's contrast that very rare syndrome with a much more common injury pattern. Instead of damage to just one side of the cord, now we're looking at an injury that messes with the very center of it. This is central cord syndrome, or CCS, and it is the most common type of incomplete spinal cord injury. And just like the name says, the damage is focused in the central part of the spinal cord, and it usually happens up in the cervical region, in the neck.
The absolute hallmark sign of CCS is that the weakness is way worse in the arms and hands than it is in the legs. You might also see sensory loss in what they call a cape-like pattern across the shoulders and back. And this happens because the nerve fibers that control the arms are located more toward the center of the cord. The typical cause here isn't something like a stab wound, but more often a hyperextension injury, like from a fall, especially in an older person who already has some age-related wear and tear in their neck.
Okay, we've looked at them one by one, but now let's do a little showdown. Let's put these two very distinct syndromes side by side to really drive home their differences. This is where we see our assessment tools in action. This chart just lays it all out perfectly. For Brown-Séquard, you've got damage to one side, that classic crossed pattern of symptoms, and a cause like a stab wound. For central cord, the damage is right down the middle. The dead giveaway is that the arms are weaker than the legs, and the cause is often a fall. You can see how the location of the damage tells a completely different story. So let's wrap this up with the key takeaways. The first step is always figuring out if an injury is complete or incomplete. The ASIA scale, with its super detailed exams, gives us that universal language to do it right. And that language lets us identify specific syndromes, like the rare cross pattern of Brown-Séquard versus the much more common arm-focused weakness of central cord syndrome. Knowing these patterns is absolutely essential for guiding everything that comes next. And that leaves us with one final thought to chew on. We've seen how a standardized system like the ASIA scale is crucial for taking care of patients today. But its biggest impact might really be on tomorrow. Think about it. When researchers in Tokyo and Toronto can precisely compare patient outcomes using the exact same scale, it just speeds up the testing of new therapies. This common language isn't just about assessment. It's about building a global effort to change the future for everyone affected by spinal cord injury.